Bismillah ar-Rahman ar-Rahim. Welcome to all our colleagues here in the Mega Online course of Anesthesia, ICU and Pain. In the 8th session of the course, this session will be live streamed on the webinar. Simultaneously will be streamed on my YouTube channel, Anesthesia Exam Preparation Course, with the name Anesthesia EPC, plus the Egyptian Fellowship Facebook group. Before we start here our session today, I'd like to express my warm condolences to the families of our Egyptian colleagues and seniors who sacrificed themselves and their lives trying to cure patients with the COVID-19 pandemic. That's why you will find the black mark on the Egyptian flag. So let's go now to the lectures of today, and we have two lectures. The first one will be the practical guide to transesophageal echocardiography with Professor Dr. Maged Salah. He is a professor in anesthesia and intensive care in Cairo University, graduated in 1995. He granted his MD in anesthesiology in 2002. He is currently the secretary of the Egyptian Society of the Cardiothoracic Anesthesia, and he had his first go with the American Board of Perioperative Transesophageal Echo, and he got the board in 2005. Apologies. And he renewed his board in 2015, so his second renewal will be in 2025. So we are talking with an expert in transesophageal echocardiography. I hope all of you here get the maximum benefit out of this lecture. Dr. Maged Salah, please go ahead and share your presentation. Thank you.
Good afternoon, and I would like to express my thanks and gratitude for Dr. Walid Al-Habashi for his support and his great effort. And I would like to thank everyone who participated in this great work, and hope our organizers and colleagues and participants are safe in these situations. Wish you all health and safety. My presentation is introduction or practical guide to transesophageal echocardiography. First of all, I think transesophageal echocardiography is an everyday practice now in intensive care and cardiac anesthesia and non-cardiac anesthesia. Regulations for the use of transesophageal echocardiography started from 2003 by classifying patients into class 1 and 2 and 3. Class 1, the use of TE is mandatory intraoperative. Class 2, it may be beneficial. Class C is not beneficial. Class 1, most common practice was using it in mitral valve repair or tricuspid valve repair. And this was the old guidelines for the use. However, at 2010, we have a new practice guidelines for perioperative transesophageal echocardiography, dependent of categorization of the use of transesophageal echo according to its presentation in the literature. So we have a category A and B and C and D. In category A, we should have a supportive literature, which means a randomized controlled trials showing statistically significant difference between for the use of transesophageal echocardiography. And actually, we do not have this number of randomized controlled trials for transesophageal echocardiography, but our use in the category B, which is suggestive literature, which means that information from observational studies permits the use of the beneficial effects of transesophageal echocardiography intraoperative. We do class C for equivocal, which is undefined, and category D, which is insufficient evidence. In the clinical evidence, where are the use of transesophageal echocardiography? In adult cardiac surgery, transesophageal echocardiography should be used in every case, especially valvular and thoracic aortic procedures, with and its beneficial effects should be considered in CABG cases. And it is used to confirm the perioperative diagnosis and detect a new pathology and adjust the anesthetic and surgical plan and detect the effect of the intervention. It's a category B2 evidence, and I explained why it is B2, because the data are from observational studies. In small children, TE should be considered on case-by-case basis, weighing the benefits against the risks of the use of transesophageal echocardiography. In catheter-based intracardiac procedure, TE should be used, and it's a category B2 evidence also. And I think many procedures like TAVI and mitral clip and closure of ASD are done under TE monitoring, which gives a very good chance for the patients. What about non-cardiac surgery? TE should be used or may be used when the nature of the planned surgery or the patient non or suspected cardiovascular pathology might result in severe hemodynamic, pulmonary, or neurological compromise. So if I have a very major surgery like transesophageal echocardiography, like liver transplantation, TE will be useful, very helpful and useful. If I have a complicated patient with valvular pathology or ischemic heart disease, TE will be very beneficial. If I have an intraoperative complication like persistent hypoxia or persistent hypotension, I should think about transesophageal echocardiography. In the critical care, according to the guidelines, the gold standard in the is the transthoracic echocardiography. If I can have the data with the transthoracic echocardiography, no need for transesophageal. But if I cannot have data from transthoracic echocardiography, like patient on high PEEP or patient with obesity or poor echo window, I should use the TE. In every case with persistent unexplained hypotension or persistent unexplained hypoxia, I should have a transesophageal echocardiography examination. This is about the indications of the use of transesophageal echocardiography in brief. Let us look again for the probe. We have many movements of the probe. We can advance the probe to the stomach and take it up to the lower esophagus or the upper esophagus. So we go in and out. We can turn it to the right or turn it into the left. So this is the second movement of the probe. We can do anti-flexion, which means bending forward or bending backward, retroflexion. This is the third movement of the probe. We can rotate it to the right or to the left. This is the fourth movement of the probe. Then the fifth and the most important and the very important and is advanced in technology is changing the angle, the multi-plane angle. When we started TE, it was uniplane. We have a monoplane creating this triangular or conical field at an angle of 0. Then we had a good addition by the biplane, so we can examine the heart at 0 angle or 90 angle like this. You look like for the wedge or the triangle is perpendicular to the 0 angle. Then the multiplane technology where electricity stimulates the piezoelectric crystals, and we can create our own wedge or our own triangular sector at angle of 0, 10, 20, 30, 60, and this enables us to have many figures and adjust the probe according to the patient heart situation and position. So it's a very great advance in technology, and these are the movements of the probe. Again, in and out, right and left, anti and retroflexion, clockwise or anti-clockwise, and the use of the multiplane. We can consider this is the piezoelectric area of the transducer, the piezoelectric crystals. We can consider it like camera. I'm having a photo of the heart from the esophagus. So I can move it backward to increase the field, or forward to zoom, or to the right to have a look on the right-sided structure, or to the left to have a look on the left-sided structure. Anti-flex to attach to the anterior stomach wall, retroflex to increase my field. So it's ideal like a camera. Here is my situation. I can be transgastric in the stomach with anti-flexion of the probe to attach to the anterior stomach wall and to image the inferior surface of the heart. I can go very deep in the stomach to have what's called the deep transgastric view, which is very helpful. I can go to the middle of the esophagus I can take it into the upper esophagus. So I can be upper esophageal, middle esophageal, transgastric, and deep transgastric. I will start by the transgastric views. Also, we should have an idea about the image orientation. Here is the transesophageal 4-chamber view at angle of 0. We can see the left side on my right side and the right side on my left side. But what will happen when I change the angle to 180? It looks like I'm looking into a mirror. So the right ventricle become on my right side and the left ventricle become on my left side. So changing the angle from 0 to 180, it looks like the image is looking into a mirror. So I will have the inverse. Changing after 90 will make it the reverse for the TE image. Here is a fibrous skeleton of the heart. Fibrous skeleton of the heart is a very important area of the heart. It supports the structure of the heart. We should notice that the most anterior structure is the pulmonary valve, and then anterior aortic valve. We should know all that anterior aortic valve is an anterior landmark, pulmonary valve, aortic valve. But when I see the aortic valve, it's an anterior landmark. Then we have the mitral valve and the tricuspid valve. Mitral valve looks like a smiling face with two leaflets. One leaflet is the anterior leaflet because it is related to the aortic valve, and the other is the posterior, which is away from the aortic valve. Here is the tricuspid valve with the septal leaflet, then the anterior leaflet related to the aorta, and the posterior leaflet. All of this is a fibrous tissue supporting the heart, and as you see, it is deficient, much weaker on this posterior aspect of the mitral valve. So you expect a dilatation or enlargement of the heart to occur on the posterior wall of the left ventricle and the posterior annulus of the mitral valve. Start by going into the stomach, taking the probe into the stomach, as you see, with anti-flexion, and then start my cone, my triangle, my sector, which is narrow at the probe and wide at the base. And let us see the first view. Here's the pathology of the first view. What it does look at transgastric mid-papillary view with the left ventricle circular in shape and with this thick muscle, and then the right ventricle is crescentic in shape and the less thin muscle with two papillary muscle, posterior and anterior papillary muscles. So let us look again. Here is the probe of the transesophageal echo. So this is the posterior papillary muscle, and this is the anterior papillary muscle, and here is the cavity of the LV, which is circular. This view is very useful for monitoring volume. You can detect hypovolemic or hypervolemic heart. It's monitor of contractility. You can see if the heart is well contracting or not. We can monitor ischemia because the anterior wall of the left ventricle is supplied by LAD, lateral wall is supplied by the circumflex, inferior wall and inferior septum is supplied by PDA, so I can monitor the three coronary vessels in this view. So if I see this video, I hope you can see it. He's hypovolemic, well contracting, non-ischemic heart from a single view. I consider this view, which is a transgastric mid-papillary, and I should mid-papillary means I should see the two papillary muscles at the same time, and I should see them connected to the wall of the left ventricle, not separate from it, like you see it now, connected to the wall of the left ventricle. I consider it with a 4-chamber view, like lead 2 and 5 in the ECG. Detect everything, detect ischemia, volume, contractility. You can have a full data from these two views on. Let us increase the angle from 0 to 90. We'll have the transgastric 2-chamber view. Here is the probe. Here is the nearest wall, which will be the inferior wall of the heart. Here is the cavity. Here is the anterior wall of the heart. I can detect from this view the volume and the contractility of the inferior wall and the anterior wall. I can detect segmental wall motion abnormality. Again, this is a specimen showing what can I see from the two-chamber view at angle of 90. Here is the inferior wall. Here is the anterior wall. I don't know if you see it, but here is the mitral valve, posterior and anterior leaflets, and the chordae tendineae attached to the papillary muscles. Here is the papillary muscle. Here is the papillary muscles, and here the chordae tendineae. Chordae tendineae, like thin chordae attached to the valve. Then I can increase the angle from 90 to 120 to have what we call long axis view. Transgastric long axis view, where I have the angle between 120 to 150. It has a very important advantage for us. Here is the probe. I can apply a Doppler line parallel to the flow across the aortic valve into the ascending aorta. So I can apply through this view Doppler to the aortic valve. Here is the cavity of the left ventricle. Here is the anterior septum. Again, this view is very useful for applying Doppler across the aortic valve. Here is the cavity of the left ventricle. Here is the aortic valve. I can apply a continuous wave Doppler to measure gradient across the LVOT and the gradient across the aortic valve. Returning to the angle of 0 and advancing the probe deeper in the stomach, we will have the deep transgastric view. Deep transgastric view can, we are looking to the heart from deep in the stomach. We have the cavity of the left ventricle in front of us, like you see, and we can have the aortic valve in an angle favorable to apply Doppler across it. So this is, we have a very important limitation when using the transesophageal echocardiography, is that we cannot apply Doppler to the aorta except across two views. One of them is the deep transgastric, and the other is the transgastric long axis view. And so those two views are very important, and we should be expert with both of them, because many times you cannot get one of them, so you should use the other. Again, the arrow points to the aortic valve. This is the cavity of the left ventricle. Here is the mitral valve. It's not clear, but we can apply Doppler across the aortic valve, across the deep transgastric view. So we are going to summarize what we spoke about. We spoke about the transgastric mid-papillary view, the transgastric two-chamber view, the transgastric long axis view, and then the transgastric deep transgastric view. Deep transgastric and transgastric long axis view allows us to apply Doppler across the aortic valve and left ventricular outflow tract, so they are very useful for it. Let us take the probe a little bit outside toward the esophagus and go to the transgastric basal view, and we start to examine the mitral valve. I want to give a brief view on the mitral valve. When I'm withdrawing my probe, here is the transgastric basal view. We call it the fish mouth view. We have the mitral valve here with the anterior leaflet and the posterior leaflet. And this photo, or this diagram, shows the anterior mitral leaflet and the posterior mitral leaflet, which is subdivided into scallops, P1, P2, P3, and A1, A1, A2, A3. So, what about this view? This upper view is what the surgeon sees when he's on the right side of the patient and open atriotomy. You will find the nearest area to him is the posterior leaflet, and the P2 of the posterior leaflet specifically is the nearest for him. So the repair of this scallop is very important. This scallop classification is according to Carpentier classification. Here is the anterior mitral leaflet, and here is the posterior in the surgical view, and this is resembling the surgical view, but this is the echo view, what we can see with the transesophageal echocardiography. Okay, again, here we have an anterior leaflet and a posterior leaflet. How to differentiate between them? Posterior leaflet is widely attached to the annulus. Anterior leaflet is narrowly. attached to the annulus, and the anterior leaflet has a longer depth, while the posterior leaflet has a shorter depth from the annulus. Again, here is the anterior and here is the posterior. Again, here's what we see it on the transgastric basal fish mouth appearance. Anterior and posterior leaflets communicate as a commissure, anterior and posteriorly. Here is A1, A2, A3, P1, P2, P3. Then when we examine the mitral valve, according to the angle we are transecting the mitral valve, we can detect which scallop we are located in. Here is the transgastric basal, we will see it now. Then we'll go for that 4-chamber view, commissural view, 2-chamber view, mid-oesophageal long axis view. According to where is the line is transects the mitral valve, we will differentiate between scallops and each other. Here's our idea. Here's the echo line transecting the leaflets of the heart. Echo line transecting leaflets of the heart. And according to it, we will see which segments we are seeing. Let us return to our transgastric views. Here is a transgastric basal view, the fish mouth. Here is the anterior commissure. Here is the posterior commissure. Here is the anterior leaflet. Here is the posterior leaflet. A1, A2, A3, P1, P2, P3. We are dividing them to define the exact area of the pathology. Okay, what about the lower? Let us withdraw from the stomach and go to the lower esophageal. We'll see the diaphragmatic right ventricular inflow view, where we can see with the probe tilted to the right. You can see the right atrium, the right ventricle, and the coronary sinus, which is the venous drainage of the heart. Here is the coronary sinus. This view is very useful for detection of coronary sinus pathology and confirming the position of coronary sinus cannula. Then let us go to the other famous view. The second most famous view is the 4-chamber view. 4-chamber view shows us the left atrium, right atrium, left ventricle, right ventricle, and the mitral valve with the anterior leaflet medial and the posterior leaflet lateral, and it's an angle of 0. Here's the view. Here's the specimen of this view. It is left ventricle RV, LA, RA, anterior long mitral leaflet, posterior short mitral leaflet. And which segment of the mitral we are speaking about? According to the table we saw it is mostly A2, P2 segments, which means the main bulk of the mitral tissue. If we have a little withdrawal of the probe, we'll have what we call the 5-chamber view. What is the difference between the 4-chamber and the 5-chamber view? The same angle, but slight withdrawal outside. We'll have the LVOT in the view, like this. We have the LVOT and the aortic valve. So if I have the 4-chamber, we will not have the aortic valve. In the 5-chamber, I will have the aortic valve appearing and the left ventricular outflow tract appearing in the view. This is the difference between the 4-chamber and the 5-chamber view. If I change the angle to 60, I will have the mid-esophageal commissural view. Here's we can see a sign which is called the seagull sign. In the seagull sign, we have 2 coaptation points, this and this. Why we do have a coaptation points? Because we pass from the posterior leaflet to the anterior leaflet, then to the posterior leaflet too. So for the scallops, there is P1, A2, and P3. And there is 2 coaptation points because we passed over the coaptation points of the mitral valve. Increasing the angle to 90, we have the 2-chamber view. We'll have the left atrium and the left ventricle. We'll have the inferior wall of the left ventricle and the anterior wall of the left ventricle. Very useful for segmental wall motion abnormality detection. Increasing the angle, here is again the 2-chamber view. Increasing the angle to the 120, we'll have the mid-esophageal long axis view, left atrium. Because we changed the angle over 90, we'll have a mirror-like image. So anterior leaflet, which was on the left, now on my left, now it is on my right. Here's the anterior leaflet. Here's the posterior leaflet. Here's the left ventricle and left ventricular outflow tract and the aortic valve. Here's the pathology on mid-esophageal long axis view. Here we have here prolapsed posterior leaflet and with rupture chordae. Here's the anterior leaflet. Here's the aortic valve and the ascending aorta. Is the left ventricular outflow tract. Very useful for detection of mitral and aortic valve pathology. Again, this is another one. Aortic valve and the mitral valve. Here's the anterior mitral leaflet, and here's the posterior short mitral leaflet, and here's the left ventricular cavity. And here's because we have the aortic valve, this is anterior septum. Aortic valve is an anterior landmark, and the coronary sinus is a posterior landmark. Let us return to zero again and take the probe outside. We'll have the aortic short axis view. We'll have the three cusps. One is related to the left coronary. This is the left main coronary, left coronary cusp, and the other is related to the right ventricle, which is the right coronary cusp. And we have here the origin of the right coronary. It's very small. And we have here the non-coronary cusp. Left, right, non-coronary cusps. And here, when spreading it, here's the orifice of the left main and the right main coronary. Again, left with the left main coronary. If we increase the angle from 30 into 120, we'll have a very focused view of the aorta, where we can measure the plane of the annulus, which is at the base of the cusps of the aortic valve, and the sinus, which is the sinus of Valsalva. This bulge is the sinus of Valsalva, and this is the sinotubular junction. So we can measure the annulus and the sinus and the sinotubular junction diameters. Let us withdraw the probe more toward upper esophagus, but we still mid-esophageal at angle of 0. We'll have this view where we have the left atrium in focus. Then we have the at angle of 0. Here's the anterior mitral leaflet. Angle of 0. Here's the posterior mitral leaflet. But the left atrial appendage appear with a ridge separating it from other cavity, which is the left upper pulmonary vein. This ridge was thought to be a thrombus in the past, but now it is known as the Comedine ridge. It separates the left atrial appendage from the left upper pulmonary vein. Here is the left atrial appendage at an angle of 0. It looks like a horn that would have a characteristic mucosa called the dentate mucosa, with the Comedine ridge separating it from the left upper pulmonary vein. Left upper pulmonary vein, we can apply color Doppler across it, and it's favorable for pulsed wave Doppler to detect velocity of blood flow across it, which is diagnostic of many cardiac problems. When changing the angle into an angle of 60, we can have what we call right ventricular inflow to outflow with slight tilt to the right, which is right rotation of the probe, like this, right and left rotation. So this with slight rotation of the probe will have the right atrium with the tricuspid valve, right ventricle with the pulmonary valve. Increasing the angle into 90 with focusing on the right atrium will show us the bicaval view with the superior vena cava and the cavity and the inferior vena cava. It's very, here's the superior vena cava, here's the cavity of the right atrium, here's the inferior vena cava. This flap or segment, this moving flap, it's called the Eustachian valve, which is a valve guarding the inferior vena cava. We can here see the central line entering the right atrium. Here is the interatrial septum separating left atrium from the right atrium. We can diagnose ASD through this view very easily. Then going outside more, we'll have this view where the aorta will be circular and will be midway between the pulmonary artery and the right pulmonary artery. The left does not appear because of the bronchus. Then behind it will be the superior vena cava. Here is the main pulmonary artery and the right pulmonary artery. Here's the aorta, and here's the superior vena cava. We can see central line is the superior vena cava. We can monitor the aorta here. We can see a thrombus in the pulmonary artery or apply continuous wave of pulsed wave Doppler across the pulmonary artery. Again, here's the aorta and superior vena cava in behind. Pulmonary artery, which is most anterior, aorta and superior vena cava. Here is it. It's very simple. Here is main pulmonary artery, right pulmonary artery, which is transverse. with a strange shadow here, but it is an artifact, not a thrombus. Here is the aorta, which is circular characteristic feature. Here is the superior vena cava with a central line seen inside it. Okay, let us go for the four-chamber view, and we have a left rotation of the probe. Left rotation to the probe. You take it into rotate it into the left side. Then we have at angle of 0 the aorta, descending aorta. Is very important view for diagnosis of aortic dissection. When I change the angle into 90, we have the long axis. I will see the longitudinal axis of this descending aorta for diagnosis, aneurysm, and dissection. We finish the mid-esophageal. Let us go upper esophageal. At the upper esophagus, we'll have a view on the aortic arch. And the aortic arch will be at angle of 0 will be longitudinal, and the angle of 90 will be circular with the origin of the left subclavian artery apparent on it. It's very important for diagnosis of dissections involving atheromas in the aortic arch and increasing the risk of strokes. Here is a summary of what we said. Here is a mid-esophageal four-chamber view at angle of 0, left anterior mitral leaflet and the posterior mitral leaflet. When I increase the angle into 90, I'll have the two-chamber view. Observe that the anterior mitral leaflet became on the other side because we increased the angle to 90. Then increase to 120, we'll have the mid-esophageal long axis. This is a transgastric mid-papillary view, which is a very famous view. Transgastric two-chamber view at angle of 90. Transgastric basal view. Here is the commissural view with the two commissures, P1, A2, P3. Here is the mid-esophageal aortic valve short axis view. Mid-esophageal aortic valve long axis view. Transgastric long axis view where we can apply Doppler across the aortic valve. With deep transgastric is the second view where we can apply Doppler across the aortic valve. Bicaval view for diagnosis of superior vena cava or inferior vena cava pathology or interatrial septal defect. Right ventricular inflow and outflow with the tricuspid valve and the pulmonary valve with the aorta in the center, showing the whole right side for right-sided pathology. Okay, this is the mid-esophageal ascending aortic view with the pulmonary artery, main pulmonary with the right pulmonary aorta and the superior vena cava. Mid-esophageal ascending aortic long axis view, descending aorta short axis and long axis view, and here's the arch. Arch at angle of 0 is elongated, when the angle of 90 it is circular, and there is a lot of other views where you can get by using the multiplane property of the TE. It is not mentioned here, but we can do it, and every day we'll have a new view and new image of the heart through the multiplane technology. And thank you.
Thanks, Prof. Magid. Thanks very much. For first of all, you postpone your holiday till you finish this lecture, so our appreciation for that. And second of all, for the very nice presentation you made. You made it look easy. I know how difficult to discuss transesophageal echo in 30 minutes, and you made it as well on time. So so far we don't have questions from the attendees, but I myself may have a question. To what extent you agree with me that transesophageal echo in the moment has a great role in management of COVID-19?
Transesophageal echocardiography is a great diagnostic tool for any cardiac pathology or aortic pathology. If you are going to do any intervention like using ECMO, for example, I use it very frequently for the insertion of cannulas for ECMO, superior vena cava and inferior vena cava cannulas. It's very useful for me, and much more than transthoracic. Persistent hypoxia and persistent hypotension require an transesophageal echo examination. Hemodynamic management, I think we can rely on the hemodynamic monitor much more than the transesophageal echocardiography. However, at a certain point, you need to have a look of by transesophageal echocardiography to be comfortable. For me, I do not get comfort for the hemodynamic assessment of any patient. It's personal for me because I'm very used for the transesophageal echocardiography, except if I look by myself and see the heart and the valves and because persistent fever may hide infective endocarditis, because persistent hypoxemia may hide shunt, because volume status management in such COVID patients is very complicated, and we have already lung compliance may be affected, so we can never detect it, because many of them have a severe pulmonary hypertension because of the hypoxemia, so it makes a great difference between the right ventricle and the left ventricle. It is useful. And in complicated hemodynamic situations, it gives me personally a comfort to do this examination at least once. And for any ECMO patients, I use it for confirmation of the position of cardiac.
Perfect. I'm so delighted you mentioned for patient with hypoxemia and hemodynamic compromise. And when you mentioned hypoxemia, you mentioned it first. My Mater University Hospital experience, I'm planning to publish soon a case series of patients who presented as hemodynamically stable patients. And they did a transthoracic echo, they've been suspicious, they confirmed it by transesophageal echo, and there have been 3 different diagnoses. The 3 of them were hemodynamically stable, but with persistent hypoxemia. The first case was tight mitral stenosis, and this is not a common diagnosis in Ireland. The second case was of acute papillary muscle disruption of the mitral valve, which is again a pulmonary edema. And the third case was one mitral stenosis, one papillary muscle disruption. I forgot the third case, but it was again an acute pulmonary edema in a context of massive hypoxemia in a hemodynamically stable patient. So again, it has a role in hypoxemia as well as the hemodynamic compromise and shock. Transesophageal echo may be more reliable for the valvular heart disease if you don't see the valves properly in a context of high PEEP in the patient of COVID-19. This is not the scenario in many situations. Sometimes we ventilate them easily because of this theory of lung hypercoagulable states and PEs. But some people are like really ARDS pattern, and we go on PEEPs of 10 and 15 and 20. So sometimes it's really difficult to get views on this patient. Sometimes the hypoxia is like the question mark behind this patient. So transesophageal echo is not just for the hemodynamically compromised patient, it's not just for the valvular heart disease. There is a lot behind, if you agree with me.
Yes, I agree with you. And if you are, your center is used for the use of transesophageal, you will never be satisfied for management of your patient unless you have a transesophageal coordinator. Your complicated patients, you will feel that you are missing something and you did not do everything. So it's make you comfortable that you made everything and everything is visualized.
Perfect. So far we have no questions from attendees side. One question is from Hassan Fahmi on the YouTube channel. When should I learn transesophageal echo in my residency? How and when? What do you advise him?
I advise him to start it with the cardiothoracic anesthesia round, and he will be able to do a lot of examinations, and then to start continue on the intensive care with the transthoracic. If you are going to learn transesophageal, do as much as you can transthoracic examination, which will make the transesophageal learning curve very easy, because you can do a lot of transthoracic examination every day, but you cannot do a lot of TE every day. Then it's very important to be enter a structured training program dedicated for transesophageal echocardiography, if it is possible. And certification. You should not consider giving opinion or data to take a decision upon unless you are well trained and certified, because you can have a very deceiving data. Like every sonar and echo, you need to be trained and certified in transesophageal echocardiography. And I think the European diploma is very, very easy and feasible, and requirements are very practical. So European certification is available for the transesophageal echocardiography very easily. So start in the cardiothoracic, continue on the ICU with start in the cardiothoracic round, continue in the intensive care with the transthoracic echo as much as you can, enter a dedicated program for transesophageal echocardiography if available, then certify yourself, finally give decisions, and you'll be an expert.
This really sounds, thanks so much again, Prof. Maged Salah. We really appreciate your share in today's lecture. Thanks so much.
Thank
and
you,
we hope you a safe trip.
Thank you, and meet you soon.